Greetings. I'm Dr. A.G. Unnikrishnan, endocrinologist and CEO at the Chalaram Diabetes Institute, Pune. Today I'm going to discuss a short case study which illustrates the use of oral anti-diabetes medications. In this case study, a 58-year-old gentleman with type 2 diabetes for 5 years has come for a follow-up. The fasting plasma glucose is 202, the postprandial is 358, and the HbA1c is about 9.3%. He follows diet and exercise and takes metformin 1000 milligrams twice a day. He is also taking glimepiride 0.5 mg once a day and occasionally reports feeling hungry just before lunchtime. His BMI is 29 kilograms per meter square and the rest of the physical examination is normal. Other than the blood glucose levels, the rest of his investigations are also normal and the history and the physical examination are otherwise unremarkable. In this gentleman, there are several choices. Because of the high BMI in the background of metformin, it is important to control his weight. The second aspect of this case is that giving an individual additional drug such as a DPP-4 or SGLT2 inhibitor will individually lower A1C by about 0.6 to 0.8% at the end of say 6 months, as randomized trials have shown. The third point is that glimepiride is causing hypoglycemia-like symptoms in this patient. So what is the best way to approach this gentleman? There's no question that every person with diabetes, type 2 diabetes as in this case, can do better with better diet and exercise. So a stricter focus on dietary control and carbohydrate restriction and of course overall calorie restriction is important. Second, it is also important to make sure the gentleman is physically active. It has been mentioned that all the investigations are normal, which means that his screening for diabetes complications is also normal. Now, an individual agent such as DPP-4 inhibitor or SGLT2 inhibitor may individually lower HbA1c by 0.6 to 0.8% at the end of 6 months. But this gentleman's HbA1c is above 9% and it needs to be brought down to as close to 6.5% as possible. So therefore, we require a drug which is stronger than either SGLT2 or DPP-4 inhibitor. A combination of SGLT2 and DPP-4 inhibitor would be ideal in this case. For instance, a combination of empagliflozin and linagliptin or one of the SGLT2s and DPP-4 inhibitors which have shown significant evidence in terms of outcome. For example, choosing a DPP-4 inhibitor, SGLT2 inhibitor, especially an SGLT2 inhibitor which has shown to give cardiorenal benefits is important. In this patient, because glimepiride is causing significant hypoglycemia, it is also good to stop the glimepiride, intensify diet and exercise. So the final prescription of this gentleman would look something like this: improve diet control, improve physical activity, continue metformin 1000 mg twice a day, stop glimepiride 0.5 mg and add say a combination of empagliflozin which has shown cardiovascular benefit in terms of reducing cardiovascular death and also all-cause mortality, as well as the 3-point MACE of non-fatal MI, non-fatal stroke and cardiovascular death has also been reduced with empagliflozin. So a combination of empagliflozin and linagliptin could be added to this gentleman. But all treatment has to be done keeping in mind the benefits and risks of the therapy, and the benefits and risks of the therapy have to be explained to the patient, and after looking at the scientific evidence, combining it with the best that guidelines have to offer, combining with it with our own clinical experience, and finally discussing and respecting patient choices will help us to personalize diabetes management better. It has been a pleasure discussing this case with you, this case study with you. And thank you so much, friends, ladies and gentlemen, doctors, for listening to me. Thank you very much.